Welcome, everybody, yet again to another episode of the NailedIt Ortho podcast, where it is our job to speak about, different orthopedic topics and, give you the necessary details to understand the topic and maybe even answer some board questions on it, okay? So I am one of the hosts, Dr. Cole, and we also have Dr. Fitz here on the line, man. Go ahead and say something, Dr. Fitz.
Hey, guys, it's me. You guys know the show is running well now that I'm here. All right. Nice to see you again.
So we're first week of residency. Let's Dr. Fitz, how's it going for you?
First week of residency. So actually, we started a little bit earlier than everybody. So I'm about 2 weeks in at this point. And, I'm finally getting to the floor to actually see what goes on. And it's a lot, man. It's a lot. I will admit it is a lot. Luckily this year, at this month, all of the interns are on the same service. We're all on the orthopedic service. So instead of it only being one or two of us, it's like 5 of us right now. So we can spread the work and just to kind of get your feet wet. But it's still a lot. And I'm kind of getting a little anxiety worried about when I'm just I'm the main guy, how that's going to go. But it's good. It's good. All the stuff that I kind of learned during med school, all these rotations, being able to use it firsthand on my own. It's good. How's it going for you?
Great. Man, everything's great. I'm on the trauma service, of course. Start off on trauma. That's a good way to start off. And up early and, you're doing work. And we first day in the OR, which is actually pretty nice. So, just kind of learning how to put in these orders and manage patients. But it's good. It's a good first week. And I guess we'll kind of see where it goes from here. But on that note, let's go ahead and move into today's episode and move into today's topic. So today's topic is one of the topics that is one of the things that we see all the time. If you're in any orthopedic surgery residency, you will see this undoubtedly, maybe one of the things you get consulted on the most. And we have Dr. Brooks Ficke here to speak about it. Now, Dr. Brooks Ficke did his residency at the University of Alabama at Birmingham. He also did his fellowship in hand and upper extremity at the University of Alabama at Birmingham. And he is now working at Resurgence Orthopedics in Georgia. And so on this episode, he really breaks it down really well. Distal radius fractures, what to do, how to look at it, what are some of the important things to look on the x-ray. So, he really does a great job. I really appreciate this and actually listened to this again and even took some more notes on it, guys. So really, pay attention and I hope you enjoy this episode.
You are now listening to Nailed It, the Orthopedic Surgery Podcast, featuring Doctors Jay Fitz and Wendell Cole.
Dr. Ficke, thank you so much for being on the podcast and coming and speaking, and it's a pleasure to have you.
You're very welcome. I'm happy to be here.
Great. Typically what we love to do is kind of just start off with some questions, kind of just getting to know you as a person, and then we kind of just jump into the case from there. And I know today we're going to talk all about distal radius fractures.
That sounds great. These are common problems that every resident is going to see starting from day one.
Yeah. So hopefully we get all this under the belt. But so the first question I have for you is,
what has your experiences through your orthopedic training taught you about yourself?
It's taught me that I need to know my personality and know how my personality affects the way that I practice medicine. My personality is fairly cautious and fairly detailed, and that translates relatively well into being a hand surgeon. But I also need to balance that with occasionally having to be aggressive with the patient and really make a decision quickly and get to know something.
And what made you choose hand? What made you go into that specialty?
It's the field that I liked. I liked seeing the injuries. I liked working with the patients. I liked the surgery.
That's awesome. And another one we have is, do you have a quote that you live your life by, and why? If you do have a quote, many people don't have a quote. Some do.
This is from my grandfather taught it to me. I don't know if it comes from anyone or anywhere, but if something's worth doing, then it's worth doing well.
And so we always want to try to go in with a one-liner, right? So that kind of describes who we are. So for example, my one-liner might be, 24-year-old male about to be orthopedic surgery intern, love traveling, eating different food, and having fun. Or Dr. Fitz may be
27-year-old male, new doctor, enjoy living life to the fullest and spending time with my family, like doing some extreme sports. Just recently went paragliding and we had a lot of fun.
There we go. It's a little bit more than one line, but Brooks, what about yourself? If you had to just have a one-liner about yourself.
33-year-old male, glad to be finally done with training and learning my way through balancing being a new surgeon and having a young family.
Awesome. Love it. Love it. So let's go ahead and get into the topic of the day, distal radius fractures. And we want to kind of just start off with just a simple case and then kind of go from there. So say you have a 48-year-old female comes into the ER and she was walking, she fell on her outstretched hand, and now she complains of wrist pain. You can see some type of obvious deformity. From there, what are the pertinent history and physical exam findings that you want to be on the lookout for?
So with every patient, I want to start with just a general medical history of what happened, how it happened, and always make sure to check the rest of her, ask her about the rest of her. A wrist fracture, it can be a distracting injury, and she may not even know that she has another injury. So a quick history, quick physical, checking everything before I start to focus my attention on and get distracted by what seems the most relevant, the wrist fracture. I want to know, as far as history goes, what happened, when it happened, how much pain she's in, what she feels like has changed from before, particularly with regards to sensation or with movement, and how her pain is changing over the course of the last several hours, because that can give you an idea as to whether she's having a complication such as compartment syndrome or acute carpal tunnel syndrome. In medical history, I want to know how old she is, what her general health is in preparation for considering whether this might need to go to the OR or not. And I also want to get an idea of whether she has known osteoporosis or has ever been screened for osteoporosis, because it is important as orthopedists for us to manage the bone and to encourage screening and management of osteoporosis.
Okay, absolutely. That all sounds great. I was going to ask, how often do you actually see that the patient comes in having carpal tunnel signs as well with this type of injury?
Relatively frequently. And having some carpal tunnel symptoms is different than having acute carpal tunnel syndrome. In an unreduced fracture, it's relatively common to have some numbness and tingling. And what you want to be able to do is get an idea of that so you can have a longitudinal picture of their exam. How bad is their numbness and tingling initially? Does it change after reduction? And does it worsen or get better over the course of maybe an hour or two? If it's very dense and doesn't improve after reduction, you want to consider an early carpal tunnel release. If it's mild, maybe intermittent, maybe it improves with reduction, it's probably safe to wait on that and observe it over the next 12, 24 hours, see how it changes over the course of time.
Okay. And what would your hand, I guess, physical exam, like what does that look like in a patient that has a distal radius fracture? Like are there any anatomical landmarks that you want to make sure are not tender, or different muscles that you want to make sure are functioning? What does your physical exam of the hand look like?
Going to start by looking at the skin, make sure there's no lacerations, make sure this isn't an open fracture in any way, because those can happen with distal radius fractures. Then move on to, and also while I'm looking at the skin, I'll observe their deformity and look at which way they are deformed, because that will give me a hint as to what to expect on the x-ray. Then I'll move on to palpation, see where they're tender. They're obviously going to be tender over the distal radius. I also want to know if they're tender over the ulnar styloid, if they're tender anywhere out in the metacarpals, and if they're tender up at the elbow. It's possible to have an elbow injury in addition to a distal radius fracture. After that, I start my neurovascular examine the distributions of all three nerves that supply the hand. The one that is most often affected in distal radius fractures, of course, is the median nerve, as we talked about with the potential for carpal tunnel syndrome.
Right.
But you can see other things. And then examining the tendon function in the hand. Particularly, you want to pay attention to the tendon function in the thumb with EPL and FPL, because particularly EPL is the tendon that's most associated with a spontaneous rupture after a distal radius fracture, and so you want to know that it was intact beforehand. But especially in fractures that are high energy, that might be open, you need to have a complete exam of all of the tendons in the hand.
Okay. And I just had a quick question. So when we do examine our EPL, I'm guessing it's going to be less commonly seen when you have apex volar versus apex dorsal, like the laceration or the tendon may not function, I guess, more.
Yeah, the rupture. It's actually most commonly seen with a non-displaced distal radius fracture. And the thought is that there may be some sort of ischemic injury that is related to the sheath around the EPL remaining intact because it hasn't been torn by the displacement, but there being some bleeding into that sheath due to the fracture. As far as volar versus dorsal displacement, I'm not aware of any data as to which one is more common for EPL rupture.
Okay. So you had this patient here, you've done your physical exam, and you have a suspicion for some type of fracture because it's an obvious deformity. What radiographs are you going to order, and then what are you going to be looking for on the different radiographs?
Mm-hmm. So depending on my exam, I definitely want a wrist x-ray. And then depending on my exam, I'll order other x-rays if indicated. Full forearm, elbow, depending on what hurts, where she hurts. For my wrist x-rays, I want 3 views, a true PA view, and it's important to recognize how to tell if something's a true PA view based on the look of the ulnar styloid, an oblique view, and a 10-degree lateral. And a 10-degree lateral is different than a traditional lateral of the wrist. When the x-ray is taken, instead of the wrist just laying on the plate, it's elevated up about 10 degrees off the plate, and this gives you a better view of the lunate facet. This is also the best way to tell whether she has dorsal tilt, volar tilt, to tell the alignment on the lateral view. It helps get the radial styloid shadow out of the way and profiles that lunate facet really well.
So really quick, just to kind of go over that one more time, just to be clear. So one of the things we're going to look for is a PA view of the wrist, right?
Mm-hmm.
A true. How do you know something is a true PA? Like, what are some of the things you're looking for?
With a true PA, you're looking at the profile of the ulnar styloid. There should be no other bone from the ulnar head overlapping the ulnar styloid. It should be on the ulnar side of the bone. It should be a straight line from the shaft up to the tip of the ulnar styloid. On the radial side of the ulna, it should have a slight curve to it. When it's a true PA. When it's a supinated view, that tends to be a much straighter appearance to the radial side of the ulnar shaft.
Okay. So we have the true PA, then we have the 10-degree lateral.
True PA and oblique. And the oblique view can help you whenever you're uncertain of exactly where a fracture fragment might be on the other views. It can help you give you a hint, something in between the two main views. And then the 10-degree lateral. And that 10-degree lateral, like I said, a little bit different than the true lateral that is commonly obtained because the arm is elevated up, and that lets you profile the lunate facet.
Okay. And so once we get these different images, which ones are you going to see the best? Because the thing that we all see on orthobooks, like the radial inclination, length, the ulnar variance, all that. So what view are we going to see those the best at, and then what are we looking for on those different views?
Yeah. So on the PA view, you're going to be looking at your radial length, your ulnar variance, your radial height and inclination. And typically, the average person is ulnar neutral or maybe 1 millimeter ulnar negative. And when you're looking at your radial length and your ulnar variance, you want to take the midpoint of the distal radius, which is kind of what you would see as an average between the volar and ulnar corners of the ulnar border of the radius, and take your horizontal line from there and then measure up or down to the head of the ulna. So that's how you tell your ulnar variance. Your radial height is going to be from that same line going up to the radial styloid. And looking at that distance, that is typically about 15 millimeters. You can accept about 5 millimeters of loss of radial height. Some people might say a little less. And then your radial inclination, using that same line, you'll make an angle from the ulnar corner of the distal radius up to the tip of the radial styloid. And that angle is the radial inclination, which normal is about 23 degrees.
Okay, that's great, because I know sometimes these lines are very, I don't know, it's just kind of difficult to understand how to draw these lines out to get the correct readings on the x-ray.
Absolutely. Before we leave the topic, I forgot to mention looking at the 10-degree lateral, because that's where you find your volar or dorsal tilt. And this one is often considered to be kind of the most important one to evaluate and really base treatments off of. So looking at the 10-degree lateral, you draw a line down the shaft of the radius, and you draw a line connecting the volar and dorsal lips of the lunate facet of the distal radius. Normal is about 10 to 11 degrees of volar tilt. In a Colles type fracture, your typical low energy, fall on outstretched hand distal radius fracture, that slight volar tilt turns into a dorsal tilt. That's the classic deformity. And our acceptable deformity is somewhere in the range of 5 to 10 degrees of dorsal tilt. Or if you are concerned that the anatomy may not be normal, you could compare it to the contralateral side and want the tilt to be within 20 degrees of the contralateral side.
So just to recap that, for maybe people that may be listening to this while they're driving, if we're looking at the distal end of the radii, where you have the scaphoid facet and then the lunate facet, mm-hmm. right? We are where are we putting those lines at? Like, where are we getting those lines from again?
So on the lateral view, you're drawing a line straight down the shaft, and I guess technically the angle is compared with a line perpendicular to that. And then you're drawing a line from the volar lip of the lunate facet to the dorsal lip of the lunate facet. And the angle of that line with the perpendicular line to the shaft of the radius is your angle.
Okay, yeah, that definitely help clears that up. I also want to know, this is more so, I mean, maybe in your practice or definitely for the resident, how often are you getting that extra fem of the contralateral hand?
Relatively rarely.
Okay.
Usually I might get it in a more high energy trauma, one that is very comminuted, where I kind of want a picture of the good arm to template off of as I rebuild this. Something that might have metaphyseal or diaphyseal extension, or that might have some missing bone.
Okay. And this is going to be a little bit different than our other some of our other podcasts, but since you see this so often in the emergency room, I was just going to ask if you could kind of give a rundown of what the resident should do, mm-hmm. As far as in the ER, right at that moment when this patient comes in, you've seen the radiographs, and now what's next?
So, you've done your initial physical exam, you've checked out the patient elsewhere. We're talking about a low energy fall, not a high energy trauma patient who's in the trauma bay and has other things going on that you have to worry about. So you want to have a discussion with the patient about health, goals of treatment, and the next steps. For this patient, assuming she has a dorsally displaced distal radius fracture, I'm going to want a reduction in the ER. Depending on what the common practice is at your institution and what equipment is available, you can go various directions with this. Commonly, ERs have finger traps available, which can be really helpful for helping you maintain length, avoiding the problem of having not enough knowledgeable hands to help you hold a reduction and put a splint on. The finger traps can simplify that process. Typically, I do a distal radius reduction under a hematoma block. Sometimes I'll have the ED give them some pain medications to help with some of the breakthrough pain, or if they're having a lot of anxiety, to help them be able to tolerate the reduction. But in an acute setting, a hematoma block is very effective at providing analgesia and allowing you to do a reduction. To do a hematoma block, assuming they have no allergies, I get about 10 cc's of 1% lidocaine. I palpate the wrist on the dorsal side to identify where the fracture is, because the goal is to get the needle into the fracture site and into that hematoma. If I can get the needle there and deliver the lidocaine there, it will spread throughout the fracture site, throughout the wrist, and anesthetize everything, not just the injection site. So I prep with sterile prep betadine or chlorhexidine, because this is introducing a foreign body into a fracture, and then inject my lidocaine. As I pass the needle in, I can aspirate just a little bit. I know that there's no major arteries on the dorsum of the wrist, so I'm not aspirating an artery. What I'm looking for is that flash of blood that indicates that I'm in the hematoma cavity, and then I inject my lidocaine. Typically, it does take 5 or 10 minutes after this injection for it to take effect, so that's a good chance for you to go and get the rest of your supplies for your splint. Going on, then the classic distal radius reduction described in the 1950s is exaggeration of the deformity. So you're going to hyperextend them to unlock the fracture, and then use traction and volar tilt or flexion to put the distal radius back on top of the radial shaft where it belongs. Then you can lock it in with pronation and hold that while you apply a well-padded sugar tong splint.
That was awesome. I'm pretty sure we're going to have a few people coming back to that from time to time. Just to recap, that was really good. So next, I mean, that's great. So now we have the patient. We have them stable for now. We're about to go talk to our attending. How do we go about, as well, in your opinion, what is the best type of way to classify these types of fractures?
So before we move on, I'll just mention that after I do a reduction, I want to give post-reduction physical exam, make sure if they were having any median nerve symptoms, if there's been any changes, and make sure that their vascular status in their fingers isn't changed. So then moving on, I want to get post-reduction x-rays, and comparison of those with the pre-reduction x-rays will also give me more information as to what we're looking at. As far as classification systems for distal radius fractures, there are 4 or 5 major classification systems. It's important to be familiar with them, particularly with the eponyms, because the eponyms for distal radius fractures are so ingrained into orthopedics and into family practice and emergency medicine that I don't think we're ever going to escape them. However, I don't really have a preference for one classification system in particular. Sometimes it's useful to use the eponym. Sometimes it's useful to describe the mechanism by which the fracture happened. Sometimes it's useful just to do a purely anatomic description of what the different fragments are and which way they're displaced. So it's important here to be familiar with all of the classification systems, because none of them is totally comprehensive and none of them completely guides treatment.
Okay. And I did have a quick question when you were talking about the post-reduction films that I wanted to quickly touch on. For that, again, since we already mentioned beforehand when we had our pre-reduction films that the most important one was a dorsal palmar tilt. In post-reduction, again, is that the same thing that we're looking at, and we want to make sure that's back to normal?
Post-reduction films, we're looking at the same indicators that we're looking at for pre-reduction. We're looking at the dorsal tilt, we're looking at the radial height, the radial inclination, and the ulnar variance.
Now, how often? So we have a patient. We did their films, and there's all these different types of distal radius fractures. How often do you see like these fractures, such as like the Chauffeur's fracture, the Barton's fracture, or the Smith calls, everything we kind of just spoke about, and like how often do you see those, and can you kind of explain what some of those fractures are?
Yeah, so like I said, the eponyms are really important to understand because it's the shorthand way that people communicate, and especially also that sometimes the ER will communicate with you when they call you up and say, hey, I've got a Colles fracture, and you need to know what that is. So a Colles fracture, described by Colles way back in, I think, 1814, though described by some French gentlemen 50 years before that.
History lesson.
I know. It's important to know your history.
Right.
So this is your classic dorsally displaced extra-articular distal radius fracture. And that's really the case example that we're talking about today. The Smith's fracture is typically thought of as a volarly displaced extra-articular distal radius fracture, so kind of the opposite of the Colles. And it's less common than the Colles.
When you say displaced, do you mean like angular, like dorsal angulation, or do you mean like?
Yeah, typically it's the angulation, though it can also refer to translation.
Okay.
The Barton's variants are shear fractures that involve a coronal plane shear through the articular surface, and they can be either volar or dorsal. So you have your volar Barton's and your dorsal Barton's. The volar Barton's shear fracture is sometimes described as a fracture of necessity because it's necessary to fix it. These predictably continue to shear over the course of the first couple of weeks being treated. If they are, if you try to treat it in a splint or a cast, and that's because the muscular forces of the arm just continuously pull against that sheared off fragment and pull it down and out of position. Chauffeur's fracture is radial styloid fracture. That name dates from the 1930s or so, and with actually cranking an engine to get the car to start. It's a fracture just through the radial styloid, typically emerges around the area of the scapholunate ligament. And in our traumatic injuries here, that can be a hint that you need to carefully evaluate the scapholunate interval and look for any widening there. Because if there's widening or gross instability of the scapholunate ligament, that might be an indication to get an MRI or do some further evaluation of that in preparation for potentially repairing the scapholunate ligament.
Are there any fractures where you definitely should almost always get like a CT scan or an MRI?
There's none that I do it every time on. For a very comminuted intra-articular fracture, I'm more likely to get a CT scan. I will almost never get a CT scan or MRI for your basic Colles, basic Smiths. Most of the time I can evaluate a volar or dorsal Barton's purely off of the x-rays. But for your multifragmentary intra-articular distal radius fractures with a central die punch piece, yeah, CT scan can be useful.
Okay, and can we go ahead and get into some of the treatment options for these types of fractures as well?
Absolutely. So the most basic type of treatment is going to be your closed reduction and splinting. For a displaced fracture, for a non-displaced fracture, obviously there's no closed reduction, it's just the splinting. In the ER setting, I like to do a sugar tong splint, and just as a personal preference, I like plaster over fiberglass for holding an acute reduction. I think it's easier to work with and easier to get a good mold on, but that's a personal preference. At the 1 to 2 week mark, I'll usually convert these sugar tongs to a short arm cast, depending on swelling, depending on whether there was a reduction performed or not, depending on how the x-rays are looking. So that's the heart of non-operative management, and non-operative management is really very effective at treating these fractures whenever they meet the radiographic parameters and whenever it's a good patient for it. There's a lot of controversy over what to do with the elderly patients who who have a little bit of displacement. They may not quite meet parameters, and that's not something that I would expect to be decided at a junior resident level. But just to understand that in elderly patients or patients over 65, the outcome studies comparing open reduction internal fixation or pinning versus non-operative treatment in a cast don't show major benefits outside of potentially increased grip strength at around the 1 year mark. Other options for treatment, starting to get into surgical options, we have closed reduction and pinning, so percutaneous pinning. So using K-wires is a classic way of treating these fractures. It has been done for years. It's very effective. And really studies don't show a great benefit to open reduction internal fixation with volar plates as compared to percutaneous pinning in some of these extra-articular fractures that have an intact volar cortex and can be well reduced and then held by a pin. The exact pin placement you're going to use in the OR can vary, but typically you'll have a pin coming through the radial styloid and across the fracture, and then also typically a pin from dorsal. And this dorsal pin may be a Kapanji or an intrafocal pin, and that pin is placed into the fracture site from dorsal, and then you use it to lever the fracture up to help you reduce the fracture and then drive it through the volar cortex. With those two pins, you can typically hold a distal radius fracture in a splint and get it to heal. And patients do very well with that kind of treatment in appropriate fractures.
Okay. And I know we spoke about some of the things that you would see on the x-ray, such as radial length and dorsal angulation and tilt, that can kind of lead you to more so doing operative management for these patients. Are there any other indications that you could tell us about that could lead you more so towards doing the operative treatment versus non-op?
Typically, it's in the medically and age-appropriate patient. Typically, it's mostly the radiographic parameters. Now, if someone comes in and has acute carpal tunnel syndrome, if I am releasing their carpal tunnel, I'm probably going to do something to stabilize the distal radius. And whether that's pins or an external fixator or a volar plate can vary based on patient to patient, based on fracture parameters. But if I'm releasing an acute carpal tunnel syndrome, I'm probably going to stabilize the fracture while I'm in the OR. Other than that, I don't think there's much outside of the radiographic parameters that pushes me towards surgery.
Okay, and the radiographic parameters, again, we're looking at the dorsal angulation, we're looking at the radial length, we're looking at the
radial inclination, radial height, and the ulnar variance. Great. Along with that volar or dorsal tip.
So I guess my question is, what patients would you use like plate fixation versus would you use percutaneous pinning versus like using external fixation or so?
If I had the perfect answer for that question, then I'd have a lot of papers published in my name. There have been maybe dozens of papers, even directly comparing those with randomized controlled trials, and like I was saying earlier, there's not a lot of really strong evidence that in the long term, over 1 to 2 years, that any of these treatments are significantly better than the others, as long as you're successfully able to restore anatomy and keep the patient moving, and particularly keep the patient's fingers moving. We don't want to have finger stiffness just because we have a wrist problem.
Okay.
Percutaneous pinning, external fixation, volar or dorsal fixation, there's roles for all of those in the treatment of distal radius fractures, and some of that is going to be fracture specific, some of it is going to be surgeon preference, some of it will be based on patient factors, like if they have open wounds or soft tissue compromise, that can dramatically change what you're going to do to manage the fracture.
Okay. And so we've gotten that down. We decided we're going to go ahead and operate on this patient. Can we quickly go over the different approaches that we'll take and kind of what we'll be cutting through, et cetera, for the distal radius?
Absolutely. So with percutaneous pinning, you're going to do the same closed reduction that you would have done in the ER. And then you're going to try to find a percutaneous route to safely put those pins through the skin while avoiding nerves and tendons and arteries, though typically you're not trying to put a pin through the radial artery. There have been studies in cadavers that show that there is no truly safe route percutaneously into the distal radius, and that's one of the reasons that a lot of people have moved away from percutaneous pinning, is that they feel like it damages tendons and it's prone to infection at the pin sites. Moving on to our typical open approaches. Most fractures currently are treated with a volar plate and a volar approach. Dorsal plating is associated with tendon irritation and tendon ruptures, though of course volar plating can be also. But the volar approach is the standard for most fracture fixation at this time. There's two main workhorse volar approaches to the distal radius, the volar Henry and the trans FCR, so that's going through the flexor carpi radialis sheath. That's my preferred approach. The volar Henry goes in the interval between the flexor carpi radialis and the radial artery. It's nice because it's extensile. If you have a fracture that goes into the radial diaphysis, or if you're trying to treat two separate fractures, a distal radius fracture and a radial shaft fracture in the distal part of the shaft, where you would be using the same one long plate to treat both fractures, it's nice to have an extensile approach, and the volar Henry is that. So for a trans FCR approach, you're making your incision longitudinally over the FCR tendon, which is typically visible or palpable in the wrist, starting from the wrist crease distally and moving proximally for a distance of 4 to 7 centimeters, probably, depending on plate size, fracture, exactly what you're going to be doing. I try to avoid crossing the wrist crease in a straight line, just like with all hand surgery, avoid crossing creases in straight lines. And so if later in the surgery I feel like I don't have enough distal exposure, I'm really struggling to get soft tissues out of the way, I can extend that with a 5 millimeter diagonal incision along the course of the ray of the thumb, or over the thenar eminence, and that lets me get a little more soft tissue laxity should I need it. After I make my skin incision, I use scissors to bluntly dissect through the soft tissues. I use bipolar cautery to cauterize any crossing veins. It's important to know that the palmar cutaneous branch of the median nerve can cross over the FCR sheath, it can pass through the FCR sheath, or it can pass under the FCR sheath. There's a lot of variability here, so you have to have take a lot of caution during this approach, just to make sure that you're not cutting that nerve, because that can lead to pain in the thenar eminence and lack of sensation in the thenar eminence if that nerve is cut. Once I have the tissues over the sheath completely cleared, I make a longitudinal incision in the volar part of the FCR sheath. I take a blunt Wheatlander retractor and sweep the FCR out of the way, and then make a sharp incision through the dorsal aspect of the FCR sheath. And that takes me deeper into the wrist. The next layer down is going to be the flexor pollicis longus, and in this region it's kind of the musculotendinous junction of that muscle. I use my finger to sweep it out of the way ulnarly, and then identify the pronator quadratus. And the pronator lays directly on the surface of the distal radius volarly. It's commonly torn depending on the level of energy of these fractures, but I identify it, and if it's intact, I release it distally at the red-white border, so you can actually see a difference between the muscle belly and the tendons and wrist capsule, or not the ligaments and wrist capsule, more distally. So distally, I release along the red-white border, taking care with my knife not to go ulnarly, not to cut anything that I can't directly see because I don't want to get the median nerve. And then along the radial border, I also release the pronator, taking care, obviously, because the radial artery is in this area. While I'm there working on the radial border, I typically release the brachioradialis off of the radial styloid because that's a major deforming force that can make your reduction much more difficult. After I've released the pronator, I elevate it up gently off the distal radius. I personally try to preserve the pronator as a distinct sheath, a distinct piece of tissue that would be repairable at the end. Technically, some studies have shown that there's no difference in wrist strength in pronation or supination with repair of the pronator, and that there is no difference in rates of tendon rupture with repair of the pronator. So technically, if it can't be repaired, there's not thought to be any harm to the patient from that situation. But if it's repairable, I try to repair it. Just as a matter of restoring anatomy. After I've got the pronator elevated off the volar surface of the distal radius, I can typically identify my fracture line. In this patient that we're talking about today, a typical Colles fracture, this is going to be a transverse fracture line somewhere in the range of 1 centimeter proximal to the articular surface. I want to be careful not to get into the joint space itself, not to take a knife in there. There's important volar ligaments. They're important to the stability of the wrist, and also I think that it contributes to postoperative stiffness if you violate the wrist capsule, so I try to avoid doing that. I like to use a small straight osteotome to open up the fracture site. If it's really fresh, 1 or 2 days, you may not need to do this. Oftentimes, these end up coming to clinic and then being done at 7 to 12 days postoperatively. And so there, when there's been a little bit of healing, a little bit of hematoma and callus formation, you may need to gently use an osteotome to open the fracture up. After this, I perform my closed reduction maneuver, and here it starts to get into a matter of personal preference as to how you do your plating, whether you put in the proximal or distal screws first, whether you use a K-wire to hold the reduction while you work. That's all a kind of a matter of personal preference, and is also somewhat dictated by the exact pattern of the fracture and how good of a closed reduction you get.
Okay, I think that was an absolutely awesome explanation. I feel like I can go and do the surgery right now to listen to that.
I'll hand you a knife.
Yeah. Well, we went a little bit longer than we usually do, but with this being so common of an injury and that you see all the time, I'm pretty sure the listeners will really enjoy this talk. I think it was great all around. But before we go, Dr. Ficke, what is a good way for our listeners to be able to reach you if they wanted to contact you?
Yeah, I'm happy to speak with anyone from the podcast who wants to reach out to me or has any questions. My email address is fickebw@resurgens.com. That's FICKEBW@RESURGENS.com.
All right, well, that's perfect. Thank you, Dr. Ficke, for coming and speaking with us, and have a good day, everyone.
Thank you all for listening to that episode. I hope you guys enjoyed it just as much as we loved making it. Now, if you enjoyed that, I need you to do one thing. I need you to just go to iTunes and leave a review, or Stitcher, however you listen to this, okay? And, we'd love to get your feedback. We really hope you enjoyed that episode, Dr. Ficke. He did a great job breaking things down. I took notes again while rereading this. And, if you want to stay updated with the new, up-to-date, or maybe even exclusive, perhaps, things from NailedIt Ortho, go to NailedItOrtho.com and join the newsletter. We may send you things before they're out to everybody else. So, without further ado, thank you all for listening. Go ahead and listen to the next episode.